Good evening, everyone. Apologies for the slight delay in opening the meeting there. I think we'll give it a couple of minutes before we kick off, just to allow anybody who wants to join us to join, and then I will introduce everybody. Thank you. Okay, I think the number of people joining us has slowed sufficiently to be confident that nobody will miss key parts of the discussion. So as long as I talk slowly with my introduction, anybody who is still to join us will still join. Welcome everybody to our first set of webinars. This is a collection of webinars focusing on what more we know in the treatment and care of leukemia patients as a result of the American Society of Hematology conference that happened in Georgia, but also online thanks to COVID-19 late last year, 2021. I'm Charlotte, I'm the Patient Advocacy Manager here at Leukemia Care, and I will be asking questions both from myself but also from the audience to our speaker today, who is Tobias. Tobias, would you mind just introducing yourself for me?
Yes, and I'm Tobias Menne. I'm a consultant hematologist at the Freeman Hospital. I'm interested in ALL and lymphoma. I've been on the ALL working group since 2011 and was member of the UCAL14 trial, and also we're trying to develop the new upcoming UCAL15 trial.
Great, thank you. So how today will work is we've got a presentation, but we will pause after each of the studies to see if anybody has any specific questions as we go through each of the sort of various different topics that Tobias has selected to share with us this evening. So do ask your questions sort of as they come to you, but obviously if you do sort of think of something later, we will try to make sure we have enough time at the end for any straggling questions as well. But I do find it useful to stop sort of in between topics to digest, and I will do my best to digest it on your behalf. So without further ado then, Tobias, you're ready to share?
How do you share? Oh, wait, there it is. Wait.
Oops.
Can you all see this?
Perfect, yeah, I can see that fine.
Wait, I just need to maximize it. Yeah, so I just give you an update on ALL and what this means for us in the community and for you as patients. So first I want to really discuss an update on the UCAL14 study, which was obviously the national UCAL14 study, which was run from 2011 until 2018, recruited to patients to the B-ALL arms and T-ALL arms. And what was presented at ASH was the randomization in the T-ALL arm, where we tried to test a new drug called nelarabine. So patients received typical ALL14 treatment, but after 2 cycles, they were then randomized to receive nelarabine or not for one cycle, and then they would just continue with their standard protocol. And the reason why we used nelarabine was that there was evidence from smaller studies that nelarabine might be beneficial for T lymphomas, but also T ALL. And people would get 3 doses. And we had to keep them in hospital because there was a known toxicity side effect with nelarabine. It can cause neurological deficiencies, acute ones, which you can normally treat, and normally patients get better. But we had to admit them just to be certain that they don't develop acute nelarabine toxicity. And we had in total recruited 144 patients into this arm with TALR. And you can see this was the kind of split. So the median age was 38 years in the standard of care arm, and in the standard of care arm where they had nelarabine, it was 36. So it is a randomized study. And it's a kind of typical population you will see with TALR. And this is the event-free survival for TALR. You can see that the event-free survival was 57% in the TALR versus 61% in the standard of care with nelarabine. So there was a 4% difference, and at 5 years, there was a 1% difference. And importantly, if you then look at the HR ratio and the p-value, this was not significant. So there was no real significant improvement adding nelarabine to the standard treatment. And you can see the same for the overall survival. There is no real difference. There might be small difference at 3 years, but by 5 years, there's no real difference. Having said this, the TAL arm actually did significantly better than the BAL arm. And this was surprising because when in the previous studies, the UCAL 12, the TAL arm did worse than the BAL arm. And we don't know entirely why this is the case. It might be because we added PEG asparaginase instead of L-asparaginase, which we used in UCAL 12. We don't know. But it's something which has been noticed in nearly all trials which happened with TAL in the world, that the TAL outcome has improved over the last decade. But if you ask me specifically why, we don't know. And we thought this might be nelarabine initially when we saw the difference, but clearly once we analyze the data, there is no real significant improvement with nelarabine. So it must be something with the backbone. So this is really the first study I wanted to discuss, and probably we should just stop here because TAL is quite rare. So we should probably just have any questions. I'm happy to discuss.
None from the audience so far. I wonder whether you could just briefly touch on what the difference between event-free survival and overall survival is, just in case anybody isn't familiar with that.
Overall survival means you just look at any patient who is still alive at some certain time point. Event-free survival means that patient needs to be alive, but also not have relapsed. So if you relapse, this counts as an event. And so it is a kind of combination of relapse rate plus overall survival. Plus also on top of this, some additional things like major toxicity, transplant, but that's not really what is really of important, but it's a combination of two things. So this is why always the event-free survival will be always lower than the overall survival, because you have the overall survival in there, but also any relapses count to this.
So I guess in summary, the nelarabine had no benefit in terms of relapse or general survival.
Right. Realistically, it's unlikely that nelarabine will become the standard treatment for specifically for TAL. I mean, based on this data, and there's also some other data which were published from other groups in children, they didn't show any significant benefit either. So I think it looked good on initial studies, but when you try to combine it in bigger randomized studies, there was no real significant benefit. But it was absolutely the right question to ask, And now we need to think about newer questions, how to improve outcome for patients with TALL, which is quite rare. I mean, TALL is only present in about 15 to 17% of all adult ALL cohort. Most of them will be BALL, but there's a small subgroup which has TALL.
And of course, we're talking about a group where there's no CAR T therapy, which I'm sure we'll come on to later, and things like that.
No,
So,
absolutely. And that's something, a way forward, I will show you later, potential, how this could be addressed, this issue, how to treat this patient when they relapse, because this is a difficult group to treat in case the disease comes back. So you need to find better treatments out there. And there were some interesting data presented at ASH, and I'll show you this later. So the next one is really just to give you an idea. We all know that pediatric ALL patients do significantly better than adult ALL patients. And there are several reasons for this. There's, first of all, pediatric ALL patients, when they present, they normally have not the so-called high-risk ALLs with bad genetics. And we always counted Philadelphia positive, but on also MLL rearrangement, complex genetics as high-risk patients. And so we always knew that adult patients have higher risk ALL from the get-go, from the genetic point of view. But it was also clear that children do significantly better, because when they were initially treated on more adult-like protocols, they didn't do as well either. But since they started to introduce PEG asparaginase, extremely high doses of PEG asparaginase, cyclophosphamide, high doses of cyclophosphamide, steroids, they have improved. And the survival in a pediatric ALL patient is nowadays close to 90% long-term survival and event-free survival. And so what people have gradually done is, in the adult cohort, they started to try to use pediatric protocols or pediatric-based protocols in adult settings. You have to be a bit careful, because children are so much better in coping with chemotherapy than adults. You give a child some chemotherapy and within a few days they run around on the ward. You give an adult the same chemotherapy and they will be in bed for a week. So you have to be careful. But so gradually over the years, people have started to use more and more pediatric inspired protocols in adult settings. And what I want to show you here is, this is the initial data. If you compare pediatrics against adult protocols, you can see there's a huge difference. And this is in younger adults, so TYA patients. You can see whenever you use an adult protocol, you do significantly worse than if you use a pediatric inspired protocol. And this was in North American region, in France, in the United Kingdom, and in the Netherlands. And this was also then shown by the GMAL experience. This was the 0703. This was 2007, and this was one in 1993. So GMAL 93 was still an adult-inspired protocol where you had the 46% long-term event-free survival. Whereas if you started to use a pediatric protocol, this survival rates went up to 65%. And it was also shown that this happened in the younger adults, but also in the older adults. You can see a clear difference. So people start to move gradually to a more pediatric inspired protocol. And this move is happening all over the world. It just, you need to define up to which age you go, because you cannot give a pediatric inspired protocol to a 60-year-old or 70-year-old. This is just too toxic. But you need to find out, and so people started with 30, then they moved up to 35, 40 with small modifications. And so you can start to see suddenly a pattern emerging. And now the GMA group presented some data, which was the so-called 08-2013 study. So this study started in 2013, and they recruited nearly 700 patients. They actually recruited 700 patients to it. And what they presented at ASH are the first kind of outcome data. They have some interesting randomizations in the study, but these were not presented because they haven't got enough data. But so what they showed us is what the overall outcome is in this kind of pediatric inspired protocol. And in this one, they have quite a lot of dexamethasone. They have significantly more PEG asparaginase doses than what we normally would give even in UCAR14, which is already pediatric inspired, but we wouldn't give as many doses of PEG asparaginase. They use more doses of high-dose methotrexate to prevent CNS relapse, more than probably what we would use. Having said this, we would use typical 2 times 3 grams. So that's, well, they used 7 times 1.5 grams. So we would have used in about 6 grams per meter squared, and they use 10.5 grams per meter squared. So they use it more. But you can see they interrupted. They give 2 cycles here, then another 2 cycles later, another 2 cycles later, and each time with some asparaginase. They also used more rituximab. And then they had some additional interesting things. If you were still Philadelphia positive after 3 cycles, that you would get some targeted therapy. And this was the kind of things that they tried to optimize in this treatment. They get more PEG asparaginase, they get more rituximab, more optimized maintenance therapy, increased time and dose intensity, and new standard induction for the Philadelphia positive ALL. They also gave nelarabine in first line for TLL, but as I just shown you, will not really show any significant benefit. So they had in total 770 patients, but they present the data for the first 705 patients because they have enough follow-up there. The median age was 35, so that's a bit lower than what we had in the UCAR14 group because our trial was open up to the age of 60, 65, while this study was only open up to the age of 55. Because, as I told you, it just becomes too toxic if you go too high. So they decided their cutoff was 55 and you needed to be relatively healthy. And most of the patients were BAL, which you would expect. In their case, they had 25% TAL, which is more than what we have seen in the UK populations. And this was their initial response rate. So the initial response rate looked good, but this is also something we see in UCAR14. Our responses are very similar. The early death rate, so due to complications, was low considering this is a pediatric inspired protocol. And this is something we would see also in our population. Between 3 and 5% who are treated on UCAR14 will die of complications of this treatment. And the response rates were very much what we would also see in the UCAR14 protocol. If I speak too quickly, just interrupt. I don't mind to. So this is what happened to patients if they were still MRD positives. They would be then stratified. So if they were BALL, they would get blinatumomab. If they were TAL, they would get some additional nelarabine. And this was in total 50 patients. And there was in total 90 patients who had molecular failure, so who were still MRD positive. But with this kind of intervention, they had quite good long-term overall survivals of 75% and 79%. And this was the results for the whole group. There's 705 patients. So the overall survival at 3 years is 76%, which is really very good. I mean, the median follow-up is only 23 months, but the predicted overall survival is 76%, which is it's great. I mean, and I can say this comparing it even to our data, the UCAR14 data, and even by age group, you can see that the younger patients do the best, but this is something we have seen in every study. The younger you are, the better the outcomes. But even in the group from 46 to 55, you still have very good 3-year event overall survivals of well above 70%. And if you look at the subtype, you also do, if it's B, ALL, Philadelphia negative, Philadelphia positive, and TAL, you all look at 3-year overall survival of well above 70%. So this data looks for me very promising, and it's something I really look forward to see some more data once they get published. This was the initial results, but I think we will gain a lot more information from the study. So it is something certainly we need to observe. And the Germans have over the years done really great studies in ALL. So it's something we need to see what is happening there. So this was the second study I wanted to discuss. Anyone has any questions?
I wondered if we could go back slightly to just a bit of context for this study. You say adults and children have been treated differently for quite a long time. And how did that come about? Did they initially, I'm talking sort of 1970s, I'm assuming, try these really strong chemotherapy in adults and found them toxic?
Yeah, so initially, obviously, the whole thing started in the 60s, that ALL at the time had 100% lethality. And obviously, ALL is, generally speaking, a disease of childhood disease. You have the major peak typically between 2 and 4 years, and then it gradually flattens, and then it gradually increases again once you get to age of 50, 60, that it then gradually comes up again. But in the 60s, the first drug they ever used was steroids. And they could notice that by just giving steroids that you could get patients into remission. But very quickly, then these patients would relapse, the disease would come back. And then they started to use cyclophosphamide, vincristine, which were some of the drugs at the time available, which were in 6-mercaptopurine, and it was in the 60s. And they started to see that there was some long-term responders and remitters, about 20 to 30%. And then they gradually started to add drugs over the following decades. They introduced anthracycline, and using anthracyclines, vincristine, methotrexate, they started to get more patients going into remission and also remaining there. One of the big problems at the time was that all of the patients often had CNS disease or CNS relapses. So they started to do on everybody total spine irradiation and CNS irradiation. And this became kind of standard in the 80s. But this has toxicity, especially in children, when they still have developing brain and spine. They ended up with quite significant cognitive damages over time. So this was something which they realized is not ideal. And so they started to try to develop new methods for trying to avoid radiation in the 90s. But then the big new improvement came in the 80s when they added asparaginase, and not PEG asparaginase, L-asparaginase to it. And this was, and they knew about asparaginase, that if you deplete asparagine in the ALL cells, that they die in laboratories. And they started to use asparaginase, and they started to improve the outcome, improved by 10-15% using asparaginase. So asparaginase became a kind of backbone treatment in the pediatric setting. And a lot of the trials initially we then tried to adopt in the adult setting, but at the time it became very quickly apparent that you cannot give pediatric protocol. And so we used in an adult setting a much more less toxic and a much more lymphoma-based treatment. And there was some successes, and there was an improvement of 40% still remained alive. But over the last 20 years, the feeling was you need to use pediatric treatments, and partially it became possible because all our supportive therapy is so much better. You can give more blood transfusions, you have better antibiotics to deal with infections, and so better intensive care provision in the hospital. So this started to become possible to go in with more intensive treatment, which in the past would have been very difficult because you wouldn't have not known how to deal with the complications very well, and you would have had a very high treatment-related mortality. And that's not something you want to have as a doctor, to have 20% dying during the first 30 to 60 days due to complications, because this just means it's too toxic. But as we became better in managing our side effects, treatment became easier to administer, and we could start to gradually intensify the treatment and start to adapt the pediatric protocol again. But
and that's where you are now.
That's where we are now, and we're still trying to find our way how far we can go with this, how far it's to be safe and not to cause toxicity, because what you do not want is having patients dying from the treatment, because then it's something gone wrong. And in the pediatric settings, they tried really hard at the moment to actually make it less intensive, because their treatment is very intensive, and they have already this kind of high cure rates of 90%. So then in the pediatric settings, they're now trying to gradually step back and try to reduce the toxicity, whereas we were just trying to, in the adult setting, we're trying still to increase the toxicity, or we're increasing the toxicity to improve our outcome. And I don't think we will ever get to the same results as the pediatric setting, because they just have certain like ALLs we don't see, and which have extremely good high hyperdiploids. They have a 95-98% cure rates, and they have about 20 to 30% of all their patients are high hyperdiploids. We don't see high hyperdiploids at all in adult settings. I mean, we occasionally perhaps see one every few years. So we have certain ALL which we know are extremely sensitive to chemotherapy, we will never see in the adult setting. So we will probably never get to the 90%. But if you can get to the Germans with 70%, and I guess with some additional changes that they will do, you might get to 80%. That's very good outcomes compared to where we were just 20 years ago.
Absolutely.
But it's something I think it's really quite interesting, and it will be interesting to see what we do about this in the UK as well. Do we adapt this kind of backbone, or do we just our backbone? That's something we need to decide as a group, as an ALL working group.
Yeah, absolutely. Sounds really, really interesting. And,
No,
and like we're going full circle in terms of bringing adults back to where we managed to get to with children, which is really interesting as well.
Yeah, no, absolutely. And this is where we learned a lot, because they have so much more cases and we know what works in them. And so we started to adapt some of the procedure and the protocols, and then just try to adjust them, fine tune them to adults.
You did mention that in this trial, those with MRD had additional treatment. I was wondering whether you could explain what MRD was and why that means you have extra treatment.
Yes, and so what happens is, so I will just show you the slide. So when we started originally in treating patients with ALL, we would just look at a microscope and see if we can still detect any disease under the microscope. And there, by definition, if you look at any healthy marrow, you will always see some blast in the marrow. And so what by definition, if you saw blasts which are immature cells, which are stem cells, and it's not possible to say when you look under a microscope of a stem cell, if this is an abnormal stem cell or a normal stem cell. Occasionally it's possible, but most of the times you cannot define what is a normal stem cell and what is not. So by definition, when they started this ALL treatment, they defined a remission by achieving a complete remission, which meant that instead of having 80-90% of the cells initially are blasts, they've gone down to less than 5%. So if you did a marrow after the first induction block, which is here PH1 phase 1, you would do a marrow, and by this time point you want to have the patient in complete remission. And you can see from the data I already showed you, you achieve this in more than 90%. But then people realize this only tells us something like we can detect only 1 abnormal cell out of 100 or 5 abnormal cells out of 100. So they started to try to improve that technology. And they initially used FISH, which could go down to 1 in 100, 1 in 1,000 cells. And then they used PCR, but only basic PCR by flow, which could get you down to 1 in 1,000. And then they started to do molecular techniques where they look at specific sequences within the cells, which are unique to this clone. And they look for this presence of this sequence, of this signature in the blood when you sample it again. And using this technology, you can go down to 1 in 10,000 and potentially even 1 in 100,000. So you have a much better idea how deep the remission is. So yes, we want to achieve complete remissions, but we do know that what is far more important is to achieve MRD negativity, because we know from lots of studies and lots of special analysis of all the different studies, if you achieve MRD negativity after 2 or 3 cycles, you do significantly better than patients who still have disease present and you can detect it with molecular technology. And there's a significantly higher chance that the disease could come back. So you need to do this test to do it. And if you nowadays are MRD positive, and especially in a B-ALL setting, you would get a drug called blinatumomab, which is now approved in the UK. In this study, it was still not approved, but also now in Germany, it's approved. So it was for those patients in this study who were MRD positive and had a B-ALL, they would receive blinatumomab. And blinatumomab is an antibody which is directed against CD19, and this can help to clear the cells so that instead of having still some circulating blast cells around, with blinatumomab, you can make them completely negative. And we also know that if you're MRD positive, we would always, generally speaking, recommend, if you're still MRD positive after 2 or 3 cycles, we would recommend that you have a bone marrow transplant. But we would still like to clear all the disease beforehand so that we cannot detect any disease, even with molecular technologies, because we know that patients who go into a transplant having no detectable disease do better than those who still have some detectable disease. Does it make sense?
Yeah, the aim is to get rid of as much as possible the first time round, which
absolutely, we need to try, if you try to cure it, it's always the best in ALL to try to cure the first time around. It's harder the second time around. It's possible, but it's harder. So it's better than to go for it, especially if you know there is some risk factors like you have detectable disease. Having said this, if you have no detectable disease, then nowadays probably you don't need a transplant and you can just continue with the standard backbone, which is less toxic, over another 2 years, and you will probably do quite well. So this was the data I pointed out. So moving now to the next study, it was a study from the French, and we know there's an antibody called inotuzumab. So there's currently 2 antibodies which we can use in ALL. One is blinatumomab, which is directed against CD19, and the other one is inotuzumab, which is directed against CD22. And this antibody binds to the cells and then delivers a drug called calicheamycin. This binds to the cells. The antibody then gets taken up into the cells, and then when it's in the cells, this calicheamycin gets cleaved off the antibody by your own cells, and then this then kills off the ALL cells. This is the principle behind. And we know that we can use it in a relapse setting where we just use it on its own, and we know that very many patients get very deep remission, but it does not last and they relapse. So what people have done is they started to try to combine it with low-dose chemotherapy. And this was some initial data from MD Anderson, where they combined inotuzumab with low-dose chemotherapy. And if they did it, these patients did actually really quite well for an elderly population. So this is something you would not use in the younger patients where you can give more intensive treatment, but for the elder population who couldn't have an pediatric inspired protocol. And you can see their response rate and overall survival is actually not bad, in 60%, 49% in 3 years. And overall survival is 56%. And I can tell you, we do not get these results with the current chemotherapy, which is we have available in the UK in this kind of cohort. So the French did something, adapted this kind of MD Anderson approach and combined inotuzumab with some additional chemotherapy, which is very much what MD Anderson had done. And they gave 2 cycles of this one. They gave initially some steroids and then 2 cycles of this. And then they gave some additional consolidation. I'm not really going into the detail now, but it's something, all these drugs and the doses is something most patients up to the age of 75 would be able, even 80, would be able to tolerate. And this was here, and this was a group, so they had treated in total 90 patients with a median age of 69 going from 55 to 84. And they used the cutoff of 55 because they also have a study currently running for younger adults, which uses the cutoff of 55. It's in the pediatric inspired protocol. So they used this one, and they saw some toxicity, but they had good induction remissions. Nearly 90% went into complete remission, which is very good for the setting. And importantly, a lot of patients became MRD negative. 73% were MRD negative after 2 cycles of this treatment. There was some liver toxicity, which we know inotuzumab can cause. There was some death during induction due to complications, but that was not high considering that's an elderly population. And yes, there were people dying afterwards, but this was mainly due to relapses than due to complications of the chemotherapy. And there was 1 COVID death. But the 1-year overall survival, so there is not yet enough follow-up, but the overall survival is 78%, and the relapse-free survival is 76%, which is excellent. In our UCAL 60 data, which just used chemotherapy, we saw typically a 1-year overall survival of about 50%, and a relapse-free survival of below just around 40% at 1 year. And at 2 years, there was only 30% were still in remission. So you can see here, if you look here at 2 years, there's not enough follow-up, but there's already a trend. You can see well above 60% are still in remission. So this kind of chemotherapy looks promising. And that's certainly something, it would be great if you would have this kind of combination in the UK. I don't know if how it will come here, but it would be great. And a lot of people think this kind of combination would be really helpful in this setting, in the elderly population where you cannot give intensive chemotherapy. So this is just something, I hope that it will come to us in the next few years, but I don't know exactly when it would come, but it would be really helpful.
Absolutely. I think
that's an interesting study, certainly.
It fits quite well with the conversation we were having around trends in acute myeloid leukemia just earlier this afternoon, in the group that can't have chemotherapy are the ones where then a lot more work needs to be done. Would you say that's the same for ALL with studies like
yeah,
this?
Absolutely. It's a population above 60, 65. It's very difficult to give them a UCAL 14 based approach. And so any kind of treatment which is less toxic, but still quite effective, would be really of benefit. And antibodies are the ideal kind of setting for this, because antibodies, generally speaking, do not have the chemotherapy related side effects, and generally speaking are relatively well tolerated. Yes, they might have specific side effects specific to the antibody, and this one due to calicheamycin, which causes some liver damage. But that's the only way forward if you want to improve this kind of treatments. And it's also a way forward to see how you could improve the pediatric inspired protocols. If you add some of these drugs into the upfront adult treatment, you could potentially reach 85% long-term overall survivals. And that's something which is currently happening in international studies, where they're starting to add some of these antibodies, which they've used in an elderly population, and use it in the upfront backbone of chemotherapy to try to deepen the remissions and try to achieve more long-term remissions so that patients don't relapse. So I think this is something which we will observe in the next decade, that this will be integrated in frontline therapy. Blinatumab and inotuzumab will just be starting to be integrated more and more.
Great, thank you. I don't think there's any other questions on this particular one. Sounds really, really promising though.
Yeah, no, absolutely. I mean, I think it will be the way forward. Now, moving to a relapse setting, and this is about CAR T cells. So what I hear is we all know that CAR T cells are currently allowed in pediatric settings and in patients up to the age of 25, including the age of 25, in patients who have failed 2 lines of treatment. And this was a study, analysis of the first few hundred patients which were treated in the USA on the commercial, with commercial Tysogen. And in the USS, also in the UK, all patients who are treated with CAR T cells need to be registered on a database, a national database. In the US, it's called the CIBMTR, which actually involves the USA and Canada. But so every patient who has Tysogen treatment needs to be registered there, and they need to give regular updates every 3 to 6 months of complications, but also outcomes. So this becomes, in a way, kind of real-world data set. And so they've treated so far, at the cutoff of the 14th of May 2021, they've treated 560 patients with Tysogen like Lucil, but for this analysis, because due to have better, longer follow-up data, they have 410 patients in the efficacy set where they look at outcomes, and then they have 490 patients in the safety set where they look at toxicities. And you can see the follow-up of this patient is nearly more than 2 years. So this patient is obviously a younger population because it is only allowed for pediatrics and adult, but you can see they had 389 patients who were below 18 years, and then they had another 160 patients who were above the age of 18. 170, sorry. They had all quite a lot of treatments. They had all 3 lines on average of prior treatments. Several of these patients had already had an allograft. Some even had some experimental CAR T cells. And there was some patient had blinatumomab. And interestingly, a proportion of these patients had some treatment just before they had the CAR T cells, and we got them into remission. But there was still a proportion of patients with quite significant numbers of blasts at the time of CAR T cells. Why is it not moving? Oh, sorry. But so this is here the outcome data, and this is so this is for heavily pretreated patients, and you can see nearly 90% of patients become MRD negative after this treatment. So that's really very impressive. And this is overall response rate is so it's 97% of patients who respond become MRD negative, but the overall response rate is nearly 80%. So most of them go into CR. And this compares very similar to the Ilyana study, which was the original study which led to the license of Tysogen. And they showed several graphs. The event-free survival is very similar for this one. So this is CAR T cell in a relapse setting where still 50% are still alive, event-free survival, have alive and not relapsed at 12 months, which is excellent considering that this patient have already failed on average 3 lines of treatment. And in the past, you would have looked at potentially 10% chance of potentially curing them. So overall survival at 12 months is 79%, and so that's very good. And the toxicity was actually better than what happened in the original study, and that is big. We are now much better in dealing with CAR T cell toxicity, so the toxicity is much more manageable. And this is something we at CAR T cell center, and we have seen this as well, and the management is so much easier nowadays. We have so much more experience, so we know what to do, and we can avoid the severe toxicities. So this is, for me, this looks really interesting. So that's something I certainly think CAR T cells are potentially future for these relapse settings. At the moment, we haven't yet got any CAR T cells approved for adult patients above the age of 25. And there is actually no currently CAR T cell approved worldwide for in these settings. Having said that, there are some studies emerging which show that CAR T cells might be effective. At the moment, they don't look as effective as in the pediatric setting, but there is newer generation of CAR T cells being tested as we speak. And there's even a study also happening in the UK for adult patients with ALL called the Auto-1 study, which is against CD19. And this is there's about 8 or 10 centers currently open who provide this study. So, it's UCL, ourselves, the Christies, and Glasgow, I think Bristol, Birmingham. So they all provide this kind of treatment, and it's certainly something be aware of, that if people have relapsed 2 times and they have BLL, that's certainly a study which could be beneficial in this setting. And this treatment, I think, will become the standard treatment in the future. It's not there yet, but I would imagine that in the next 1 to 2 years, we might have CAR T cells available in a relapse setting. As it isn't a very expensive treatment, but has certainly there's some benefits, and you can get responses where chemotherapy would fail. So that's certainly something we need to observe.
Yeah, that was going to be my question, really, is just if you could elaborate a little bit more on why it's important to do this sort of checking of a clinical trial over time, in terms of whether we see the same or similar results.
So at the moment, there have been lots of recent studies which were approved based on what is called phase 2 studies. Phase 2 studies are not randomized studies where people just get selected. And if you just select some patient, you might introduce some form of bias. And so the CAR T cells, all the CAR T cell treatments were approved based on having only treated 60 to 80 patients. And the outcomes looked all very good. But there is always a concern if you do this one and you only compare it to historical controls, that there might be a bias and the data might be not as good. And so the reason why they asked us, and also in other countries, to do this is these treatments are extremely expensive. I mean, cancer treatments are normally expensive, but CAR T cell treatments cost about £300,000 one shot. So, so because of this, any kind of regulator who approved it asked then the different networks. So in the UK, we need to have our own database on all our patients treated, which they will then use for commissioning in the future, because they want to see that obviously this treatment is very expensive, but does it have similar outcome data as the original study said? It doesn't need to be exactly the same, but it needs to be somewhere in the same ballpark, because otherwise it might be just very expensive treatment. And if it's used as palliation, then it would become very unaffordable over the time, especially as CAR T cells will expand and CAR T cells will go also into other treatments in the future, not just ALL and lymphoma, but it's likely that it will be used for myeloma, for TLL, for low-grade lymphomas. So they need to show that it's relatively cost-effective and it's better than any other treatments out there. And yes, certainly it looks like it's better. And looking at Tisagen, I think the data look very promising. And actually in the UK, we have seen very similar data. And they were presented the year beforehand, that the outcomes are better than even on the trial data. So so I think Tisagen in this setting looks extremely promising. And yeah. I'm certain this will just stay as a treatment, and it's become routine treatment in the younger patients, and hopefully in some point in the future we will have some form of CAR T cells in the population above 25.
Yeah, absolutely reassuring all around. Thank you.
Yeah, no, absolutely. And so moving to the next one, that's another CAR T cell, and this was presented by a Chinese working group in Peking. And they actually looked at developing CAR T cells against TLL, which so far no one has ever been able to do successfully. And this group was able to create some T cells which looked like they worked in mice. I'm not going into the details, but it shows that if you inject this mice with T cells and you just use normal cells, these mice will all have leukemia everywhere. This is a kind of purple patch. If you then do the same thing and give them CAR T cells direct against the T cells, you see when you inject them at day 0, you still can detect some cells, but then by day 7 and day 14, these cells have not expanded. And so this suggests that the T cells just kills them off. So this was in mice models. And so they treated now 14 patients with TALL. Most of them had several lines of treatment. And they have followed them up for nearly a year. And initially you start with a low dose because you never know what potential toxicity you might observe. And then you gradually increase the dose of treatment. And then they had a medium dose, and then they had a high dose. But when they used the high dose, they had some toxicity, so they went back to the medium dose. So they treated 11 patients with a medium dose of CAR T cells. And they were able to manufacture this quite easily. 100% of patients had their CAR T cells infused. The age group was between 3 and 42. And this is so far the outcomes. So they had 92 patients achieved MRD negative CR. So that's very good. The issue then is that then they de facto transplanted everyone afterwards within 60 days. So what we don't know is if this treatment would have potentially be even curable on its own. They had 2 patients with whom they did not transplant, and 1 patient relapsed and died, but the other patient has remained in remission at 180 days. So that's something which will be certainly worthwhile to observe. At the moment, they only see it as a bridge to transplant, but to achieve 90% CR rates with MRD negativity is in someone who they had some of them had 4 or 5 lines of treatment is completely unheard of in a TLL setting. I mean, when we have about 2 lines of treatment for TLL, and once they fails this one, there's not a lot else you can do. You're looking at palliative chemotherapies, and then to have something like this to achieve this with 1 single dose, 90% going into complete remission is very impressive. So that's certainly something we need to see how this works. And this is something, I mean, it could change the way how we manage patients with TLL in the future. Obviously, at the moment, it's only 1 single center studies, but the Chinese have been very good in developing CAR T cells. And I wouldn't be surprised if this will be moved by the company and produced, developed further. So it's certainly something worthwhile to observe. So this certainly looks very promising, and the toxicity was very not dramatic. So you can see there was some grade 3 toxicities, which is kind of severe but not life-threatening. Grade 4 are life-threatening. Grade 3 is severe, grade 2 is moderate, and grade 1s are mild. So there are some severe, but only 1 patient had severe CRS, which is the typical side effects of CAR T cells. And there was good expansion of the CAR T cells in all patients, and the mean level under the peak area was very good, and this is something we normally see in CAR T cells. So these CAR T cells really expanded well. So this is really an interesting study, and I think when we all looked at people who looked at this, thought, yeah, this looks promising. It's too early to say, but it's certainly something I think we will hear more from this construct.
It's always good to hear there's that things are being translated into the group that is more rare and things like that.
It will be good because TLL is really difficult. We haven't got any antibodies there. So we are just relying on chemotherapy to get something like this. Nelarabine, as I just showed you, does not look very promising. So it's something like this where you get this kind of extreme responses is always something fascinating to see. And I wouldn't be surprised if in the next 5 years this will become the kind of standard for TLL treatment once you have relapsed. But we just need to see a bit more longer follow-up data and with a bigger cohort.
Could you just clarify on the expansion and persistence of cells? Is there a correlation between the number of CAR T cells you have and how long they last and the quality of response?
Yes, the problem here is obviously there's no persistence because they all underwent an allograft. So you just destroyed all the T cells there. So that's very difficult then to say what actually happened to it. What we do know is from most CAR T cells, you probably need some persistence for probably 3 to 6 months. You don't need persistence for longer, most likely, but you need to have some, because the problem is that as, I don't know if people are aware of T cells, but what happens with CAR T cells is you take your own T cells, which normally attack abnormal cells and destroy them. And T cells are very important for us. They are there to prevent that we develop cancers, that we deal with viral infections. And they are always on the lookout for abnormal cells. And if they see them, they will just go attach to them, release some factors, which then leads to cell lysis. Then the cell dies, and then the T cells just march on to their next target. This is how they normally work. And they are very programmed, and they normally do this. But after a while, if they see the same target again and again, they start to tolerate this. And this is a problem why cancers can emerge, because T cells are very active preventing cancers emerging, or leukemia or whatever. But occasionally they develop tolerance. And so what we try to do is we take the T cells from the patients, but then we reprogram them that they start to detect against the abnormal cells. In this case, the leukemic cells. And then we infuse the cells, and we infuse typically 100 million cells of this genetically changed T cells, which are the patient's own T cells. And then when they start to detect the leukemic cells, they start to expand from 100 million cells to 100 billion cells, even potentially trillion cells. And each of the cells has the capability of killing off 10 to 50 cells within few days. So you can see the potential of this treatment. The problem is with T cells, when they start to attack and attack and attack, they after a while, they just get very tired and then they die. And if they die, then you have a problem, because then if there's still cancer cells surviving, then they will just come back again. So you need to have the cells doing this initial expansion, what you can see here on the left curve, but then you need to also see ideally that they still persist for a bit longer, that they persist for, no one knows for how long they need to persist, but that they persist to deal with some remaining abnormal cells which have survived, and that they get killed off by the cells. And this is what CAR T cells do. But you only have one shot with them because it's so expensive. You just give it once and you hope that the cells expand and stay there for a while. And this is where there's still a lot of work going on how to improve it so that you make that they expand, but they also stay for a bit. But you don't want that they stay too long, because then they might create toxicity in the long run. So you need to find the right balance. But it is certainly something which has revolutionized the treatment in ALLs and in lymphoma. And I think it's something we will see more happening also across other disease and also TAL. So that's just something to be aware of. Anyone has any questions about this?
Not at the moment, no. Thank you.
So this is just a study I just wanted to mention. It's an interesting study. I don't know how useful it will be, and it's something we need to see. So Philadelphia positive ALL in the past was very difficult to treat. But since we have the so-called proteasome inhibitors, imatinib, dasatinib, ponatinib, nilotinib, patients have done significantly better. There is, however, some mutations which occur after a while, which can then lead to that this nilotinib, dasatinib, ponatinib don't work. The most common mutation is the T315I mutation, but there's also other mutations. And then once you lose the benefit of the TKIs, then the Philadelphia positive ALL becomes much more difficult to treat. And so there have been other ways studied to see how you could help to get, again, control of the disease. And one of the ways is to use a so-called stump inhibitor, which is a direct inhibitor of ABL. And you can see it on the right-hand picture. In the blue picture is nilotinib, which is a TKI, which binds to the ATP site. But now there's this development of this ABL, direct ABL inhibitor, ABL001, ascitamide, which binds to the groove here in the ABL domain. And so what they're trying to do is in this study is to see if this combination with the other drugs can help. So with dasatinib TKI in patients who have become refractory to TKIs on their own. And so this is a population of patients, many of them above 50 years of age, because this was a requirement, but you could also have younger patients who were unfit for any significant aggressive treatment. So there was some side effects with this treatment, but importantly, there was some responses over time with log going down over at 1 month and 3 months when you combined it. So there is some suggestion that this kind of combination might work in the future. It's just early results, but it might be something we might start to see coming to us as in a combination for treatment for patients who have failed standard treatments and have failed 2 different TKIs in Philadelphia positive ALL. So my conclusion is that the German data, which I showed you initially, look very promising. The French data combining inotuzumab with low-dose chemotherapy in the elderly population looks again very promising, and I think this is things we will put some of these approaches if they become available, especially the inotuzumab is funded. And T-cell like CAR T cells look good, and the real world data look very good. So this is something which will stay with us, and I just hope that at some point we will have CAR T cells also for the population above 25. And the beauty is with CAR T cells, you can give CAR T cells also to patients who are 75 years old. When we have treated now patients who are 80 years old with diffuse large B-cell lymphoma. So this treatment is much better tolerated, and that's something we need to see how this goes, but I wouldn't be surprised if at some point we can start to use CAR T cells also in the population above 25. And then for TAL, certainly CAR T cells targeting CD7 look like a potential answer, but it's still early, and we need to see if this is only then as a bridge to transplant or if we can use it just to directly cure the patient, and that's something we only time will tell us. But that's certainly something interesting. So how does it change our treatment in the UK? At the moment, it doesn't. There wasn't anything groundbreaking at ASH, which will change our treatment straight away. So at the moment, we would still continue giving upfront treatment in those patients who are MRD positive, post-induction, 2 cycles, we will give them blinatumomab as a bridge to allo. We would still transplant patients who are high risk and who are MRD positive, and we would either use a risk adapted or myeloablative depending on age and fitness levels. We would currently, there's this study open, which is an all-together study in children, but up to the age of 30, which just opened, and this is very much a pediatric inspired protocol. In other countries, it's open up to the age of 45. In the UK, currently, it's only open up to the age of 30, but this might change. We have this ALL-RIG study, which is a study in a transplant study. When patients have a transplant, they get randomized to have standard reduced intensity transplant or one where you give some radiotherapy as well. And that's a study just to identify what's the best approaches in patients who require a transplant, to identify what's the best conditioning is. And that's an important study because no one knows, and there has never been any study being done worldwide to look at what the best treatment is. For the relapse patients, you have inotuzumab available for the Philadelphia negative and the Philadelphia positive relapses. You have blinatumomab available for the Philadelphia negative only for frank relapse. You have ponatinib available for those patients with a Philadelphia positive relapse who were on imatinib or who did not tolerate imatinib. So this, you go straight from imatinib to ponatinib, sorry. And then we have tisagen like Lucil for patients who have failed 2 lines of treatment and who are less than 20, who have 25 years or less. And this is for patients with Philadelphia negative and Philadelphia positive ALL. And then asciminib is currently available via compassionate access scheme and via Novartis for patients with Philadelphia positive B-ALL, as long as they have failed 2 lines of TKI. And this is just some studies which are currently run in the UK on ALL, on top of the ones I mentioned, but these are smaller ones. This is the one patient for patients who have relapsed ALL, who have failed all the standard lines of treatment. If they have a RAS pathway mutation, then they can receive selumetinib with steroids. And we know that about 35 to 40% of patients who relapse after initial treatment develop RAS pathway, and this seems to be one of the driving mutations to which leads to relapse. So that's something which is they're tackled with this selumetinib. That's a study which is ongoing, and we have seen some good responses, but they last for 6 months, but not much longer than this. So if you go on a study like this, you will need most likely a transplant to bridge you somewhere. And then there's some additional smaller studies which I haven't really recruited, and I wasn't even aware of these ones, but I just pulled them. So there's a study where you combine blinatumomab with an AMG monoclonal antibody that binds to PD-1 for the treatment with relapsed refractory B-ALL, and that's run at the UCL. Then at Gosh and Newcastle in the Pediatric, there's a study combining venetoclax and giving venetoclax in patients with relapsed ALL, but it's only in the pediatric settings. And then there's another study evaluating chemotherapy or venetoclax in young patients with relapsed ALL, which is also open in Birmingham, Newcastle, the pediatric hospital in Marston. And this was really it. This was the highlights of ASH.
Great, thank you very much, Tobias. And I think you say there's nothing groundbreaking, but I've taken from your presentation hope, especially for those.
Oh yeah, there's nothing groundbreaking at the moment, which will be game changing.
Yeah.
At the moment, but you can see there's several of the studies which probably show you the way forward. You just need to get more data. Mm-hmm. And this unfortunately will still take a few years, but you can see, I mean, for us in the UK, I think we need to look carefully at the GMAL data, and it's something we need to see if we adapt some of the approaches of the GMAL group. And the GRAL data look good, but inotuzumab will have to go through NICE to get approved because it's an expensive drug, so we couldn't just, unfortunately, just start using it. I would love to use this combination, but because the data look good from the MD Anderson, and the similar data has been also shown by the SWOG group in America, and now the French as well. So this looks like a really nice combination for the elderly population, but we wouldn't be able to give it because it's not gone through the NICE process, and this will, I don't know how long it will take if this will ever go through the NICE process. That's something we need to see. But it's something. So there are some certainly waves forward, and you can see the idea how things might look in 25, 26. Some of them might even a bit earlier. I hope there's some suggestion that we might get CAR T cells by the end of the year. It is certainly due to go through the NICE process for relapsed B-ALL, but it's not yet clear when exactly, but the expectation is that it would be by the end of the year that it would be discussed. So that's something, it's certainly something we need to see. And then otherwise we just continue with our current standard, and we should always use now rituximab for patients who are CD20 positive, because that's now allowed, so we can use rituximab.
Great. So if there's no other questions, I hope everybody found that sort of a summary of a really useful summary of where we were going. I think, yeah, everybody who asked questions, I think we've sort of addressed them as we were going through anyway, which was really, really helpful. In which case, it just remains for me to thank you, Tobias.
And shall we go through the questions just now?
I think
there's 5 questions.
The only one you didn't answer, actually, now you say it, is it was a lady asking about whether her particular long-term side effect was common, because it was when we were talking about the history of treatments and how we got to the German study, and she says that she's had she has multiple brain tumors as a result of treatment in 1973, and wondered whether that was common.
Did she have radiotherapy? Obviously, I don't know, but if patient had radiotherapy at the time, yes, this was one of the side effects which people did not realize at the time, obviously, but over time we now know that if you had CNS put, if it wasn't, then that's not something you normally would find, brain tumors. But if you had radiotherapy, yes, and this is one of the reasons why we try to avoid radiotherapy. But it's also, we try to avoid it because as in childhood, radiotherapy damages your development, your brain development, and your spinal development. So people who had radiotherapy, which at the time was a necessary thing to do, because there wasn't really any good treatment option to prevent CNS relapse. So until the latest, even in adults, we gave standard to everyone CNS radiation to the spine and the brain. In adults, it was better tolerated because obviously the brain has already developed. But you could get long-term toxicities and cognitive impairments. So this is something which we now try to avoid. And nowadays we would only give CNS radiation to patients who have active CNS disease. And even then we would normally think about other options. I mean, we still normally would give it, but some people would just go in with high-dose methotrexate cytarabine. So that's just something, yes, we need to be aware of.
The other thing I think we could possibly just elaborate on really quickly, someone's mentioned that they've had immunotherapy treatment. I think they said blinatumomab. Yes, they did. And they asked what more research is being done on these treatments, and you have talked about inotuzumab.
Therapies. Oh yeah, absolutely. Yeah. Blinatumomab, I just seen this comment here about blinatumomab, and yes, blinatumomab it's a bit unusual to relapse 13 years after your initial ALL treatment. I mean, that's very unusual. I mean, most of the people, it's a relapse. You relapse within the first 2-3 years. And I mean, after maintenance, it's still, there's a chance of relapsing up to year 5. So now maintenance typically takes about 3 years from the time you started until you finish, takes about 3 years, the whole treatment. And then you still have, by the time you finish maintenance, the chance, if you're at this time point in remission, the chance that you remain in remission is close to 90%. And then if you wait another 2 years, your chance of staying in remission is well above 95%. So what it's very unusual is to see late relapses in ALL. I mean, especially this extremely late relapses, like what this person described here, is at 13 years. Blinatumomab is significantly better nowadays. Blinatumomab has revolutionized, like inotuzumab has revolutionized the treatment, is much better tolerated. You don't have any of the side effects of chemotherapy. You're not losing your hair. You normally don't get admitted a lot due to infections. And there's a lot of treatment currently. There's a lot of protocols happening where you combine either blinatumomab or inotuzumab with chemotherapy up front to do this. What we do know is that blinatumomab and inotuzumab on its own will be very good in getting you into remissions, but the chance of relapsing is still very high. So you need to combine it with some form of chemotherapy to get the maximum effect. And this looks extremely promising. Where blinatumomab works extremely well is in Philadelphia positive ALL. So if you combine blinatumomab with the TKI, either dasatinib or ponatinib, you're getting amazing responses and also long durable responses. So there is now data out from the Italians, but also from the MD Anderson, that you're potentially looking at 2-3 year event-free survivals of 90% plus, which is something completely unheard of in a condition like Philadelphia positive ALL, which 15 years ago, you would still have only a 20% chance of long-term survival. And so I think this is probably something we will see in Philadelphia positive ALL. And that's something I wouldn't be surprised if we will start to see in the next 1 or 2 years' time, that blinatumomab together with dasatinib or ponatinib will become the standard treatment in frontline Philadelphia positive ALLs. Might not be next year, but perhaps the year after, because this data are just absolutely beyond anything we have seen beforehand. Where I also can see where it will be really beneficial starting to use it in frontline treatment, not just for the MRD positive, but where it gets integrated into the protocol. And there's now different protocols looking at different ways of doing this. There's some protocols where they use it combined with chemotherapy. Some people use it as just as it's kind of third dose. You give 1-2 inductions, and you give cycle of blinatumomab, then you give some other treatments, and then give another form of blinatumomab at the end of the consultation, and then you might just give some additional blocks during maintenance. And this is where a lot of people work currently at, is how do you intercalate blinatumomab and inotuzumab into the backbones of your current chemotherapies. And by doing so, you try to improve the outcomes, but ultimately you then also try to reduce the toxicity by taking out some of the chemotherapies. And that's something we will have to work out. On their own, they will work well for a while, but in a relapse setting, you generally speaking would still need a transplant. And in a frontline setting, if you just would give it on their own, you probably cannot cure these people in high proportion. Yes, you will probably could potentially cure 10 or 20%, but you need some chemotherapy to really get the successes. It's different in CAR T cells. CAR T cells on their own seem to cure people at a very high percentage.
Great, I think that's really helpful as people commenting that we've been really thorough and clear, which is always useful to know. Sounds as if we've still got a long way to go, and some of the trials you presented at the end, I think it's always nice to think about where we're going to be at ASH next year as well. Maybe not next year, but in the future. That was, yeah, there's still a lot of work ongoing in the UK.
Yeah, no, there's a lot of things happening, and over the last few years, there was nothing, and then suddenly we have now blinatumomab, inotuzumab, which became available, and ponatinib became available in the last 4 or 5 years, and now CAR T cells are coming. So, having been in an area where there was not a lot and it was all just chemo-based, it's not lovely to suddenly see some non-chemotherapy-based treatments starting to really come to the forefront, and they look very promising. And you can just see how the field will develop in the next 5 years to 10 years time.
Absolutely. Great. So there's no more questions. I think we can say thank you again, Tobias, for a really informative presentation.
Pleasure.
If anybody wants to review anything that's been said,
I will send you the slides.
Thank
so
you.
If you want to forward it to anyone, I don't mind.
Great, thank you. I just want to say we do record the webinar as well, so hopefully they'll find that useful to review exactly what you've said around the slides as well. But absolutely, that would be really handy. Thank you. I did want to mention particularly a couple of other webinars that may help if you were sat here thinking, well, I'm not quite sure what CAR T therapy is, for example. Just before Christmas, we did a bit more of an introductory level CAR T webinar with some lovely doctors from London. So do check that out and then come back to this webinar if you would find that helpful. We also have information on the website about immunotherapies and how immunotherapy is different to chemotherapy, which may also help you contextualize and understand this presentation we've had today. So if there's anything more that you specifically need from us and you go away and think about, do have a search through our website, through our old webinars, which hopefully will help with that in the future. Next slide, please. Specifically on booklets, we have a range of booklets on ALL covering both treatment and sort of general information you need to know post-diagnosis. So you can now order these from our new fancy online shop, which is very handy. So do have a look at the website if you're looking for specific information on a particular topic. Next slide, please. We obviously have a range of support services. We've talked a lot about treatments today, and I'd recommend in particular, if you are still a little bit unclear on how any of this applies to you, if you've, for example, have unfortunately recently relapsed, or if you've just been diagnosed and you want a bit more of a conversation about treatment options or clinical trials, I'd really recommend our advocacy service. We are specifically there to sort of talk about pros and cons of various things and to help you come to terms with the information that you may have been given and the wealth of information that's out there. So really would recommend that. We're more than happy to chat you through anything. Next slide, please. Just like to mention a couple of support groups that are coming up. So if you've had a transplant or are expecting to have a transplant soon, actually a couple of days' time, we've got our next support group meeting for people who have who've had a bone marrow or stem cell transplant. Also got our next meeting nationally for everyone who is affected by ALL, that's a patient themselves or friends, family. But we've also started a special separate meeting for friends and family of people with acute leukemia, recognizing that you need your own space to talk to each other. So I really hope you find those particular meetings useful. Next slide, please. I've already mentioned the advocacy service, but here's just a bit more detail on how to get in touch with us. We've got a specific email, advocacy@leukemiacare.org.uk, but you can also reach us via the helpline. Just call up and explain what you'd like to talk about and you'll be directed to the right people. Next slide, please. A couple of fundraising things to mention. We're really excited to announce the Step Out for Bot Leukemia challenges back, which some of you might remember from September. If you want to help support us at Leukemia Care with this sort of initiative, webinars, etc., but you don't want to sign up for something crazy like the London Marathon or a skydive or something intense like that, Spot Leukemia is really good because you can set a goal that you think is realistic but challenging for you, and ask people to support you in your goal of reaching that. So do get in touch if you're interested in that one. Next slide, please. Obviously, we're on all social media if you do use the internet, and we'd like to keep up to date with the latest news, so do follow us there if you use those. Next slide, please. Just a reminder of our contact details and also contact details of the Acute Leukemia Advocates Network. Thank you to them for helping us put this webinar together and for promoting it to their members, and I hope their members found it equally as useful as we did today. And again, all that remains to say is thank you to Tobias for a really interesting presentation. Nothing groundbreaking, but making nice steps in the right direction for our patients, and hopefully next year we'll be able to say something equally as positive. Thank you for your time today. Have a good evening, everybody.